Okay, got it. Okay, thank you very much, Angras, for this presentation, introduction. And so I should be able to share my screen now. Okay, it works. Did it work? Okay, yes, so thank you very much for the invitation. It's an honor for me to be here presenting. Yeah, Angras already introduced me. I'm a biologist, as you said, so, and I'm working for almost 10 years now in the Pathology Institute of the University of Bern, together with our parent. And in particular, focus on understanding the mechanism of progression of pancreatic neuroendocrine tumors, focusing mainly on epigenetics. But I'm also interested in developing a new model which can be exploited for precision medicine approach in pancreatic neuroendocrine tumors. So I wanted to start with this picture, which I recently found. And I think it's really spot on, not just because of the animal in this picture, but because what I wanted to tell you today is that to really target and tackle PanNET or disease or specific disease, we really have to know what are we dealing with. We really have to look it carefully and really have to know exactly what are the features and the characteristics of the disease in order to better treat it. So when we're talking about conventional cancer therapy, the idea is to consider tumors and PanNET as well as a unique disease, as one disease which could be treated with one specific drug, one treatment, which unfortunately would work for a bunch of patients, for a small number of patients, but would have a very low or no effect for the majority or for the rest of the patients. Well, when we talk about precision medicine, the idea is to find the best treatment for the specific patient based on the specific features of these tumors, based on the molecular feature of the tumors, so performing molecular profiling, or also based on a specific drug response measure in vitro. And so when we're talking about molecular profiling, there are different aspects of the tumors that we can actually look into. And today I would like to give you a list of things that we could actually look into, which can help us to better know our enemy and therefore to better treat specific tumors. So the first thing, of course, that has to be done is the correct diagnosis and followed by pathological classification. Because I know for NET, sometimes diagnosis take very long time. Pancreas is formed by 3 different types of cells. We have acinar cells, which can generate a actinic cell carcinoma. We have the cells of the duct, which can transform and develop into ductal adenocarcinoma. And we have the islet or Langerhans, which are our favorite cells, so the endocrine cells, which can instead generate pancreatic neuroendocrine tumors or pancreatic neuroendocrine carcinoma, although the origin of the neuroendocrine carcinoma is still debated. So with the terms neuroendocrine neoplasm, we include both neuroendocrine tumors, which are very differentiated, slow progressive tumors with a specific genetic background, and also neuroendocrine carcinoma, which are instead aggressive tumors with a very rapid progression. They are poorly differentiated, and they have a typical mutation in p53 and retinoblastoma protein, which are mutation often occurring also in the adenocarcinoma. That's why sometimes the origin of from the neuroendocrine cells is challenged. Neuroendocrine neoplasm must express the neuroendocrine markers, synaptophysin and chromogranin A. These two markers are crucial to make a diagnosis of neuroendocrine tumors because they are the marker which are expressed by the neuroendocrine cells. So once we know that this is a neuroendocrine tumor, the pathologists perform the classification, which is stratification of the tumors based on the proliferation rate, which tells us already a lot about the biology and the behavior of the tumor. Tumors are neuroendocrine tumors are classified in G1, G2, and G3. G1 tumors have a low proliferation rate. G2 are a proliferation rate between 3% and 20%. And G3 are instead have a proliferation rate between 20 and 50. Neuroendocrine carcinoma, beside the undifferentiated, they are poorly differentiated, and they also have a much higher Ki67, which make them extremely aggressive. So on that we can so in that classification we can add the TNM staging, which is which indicates how much the disease is spread if we have metastasis in the lymph nodes or in the liver, for example. Here is just an example how a grade 1 tumor look like. We have very few. The brown one are the proliferating cells. You see there are very few. The G2 tumors has already a higher proliferation rate, more positive cells, and a G3 tumors, it's very different. So you can tell that this tumor is growing much more and has a higher proliferation rate. So it's hard to believe that these tumors will all respond similarly to different treatments. This already is an indication. Is an indication or is a characteristic of the tumors, which may induce to a specific therapy decision, and possibly, I mean, they could respond differently to different treatment. Although yet there is not much data about a different response based on the proliferation rate on the treatment. So grading is the most powerful prognostic marker that we have up to date, and clearly stratify patient based on the disease survival. Grade 1 tumor have a quite good disease survival rate. G2 tumor are in between, and G3 tumors are much more aggressive. And this is a similar analysis, a bit more recent, but the results don't change so much. So already the first thing that we can look at, so proliferation rate, tells us a lot about the tumor behavior and could really already steer specific therapy decision. We can do a step further, and we can look into the genomic of the tumors. The genomic, it's the to looking for the mutational rate. And when we're talking about PanNET, in 2017, it was published by Scarpa group, a complete molecular landscape of mutation in PanNET. What they found is that it was already known that 15% of the pancreatic neuroendocrine tumors carry mutation in genes which are involved in the mTOR pathway. And this is quite interesting because actually we can target this pathway with specific therapy, such as everolimus, for example. mTOR is not only regulating cell proliferation, it is also regulating angiogenesis and autophagy, which are also targeted with anti-angiogenic treatment. However, yet there is no evidence that patients with such mutation would respond better to one of the other treatment, or they would actually respond better to everolimus. So the situation is extremely complex, and just the genomic alone probably is not enough to tell us to steer therapy decision. What is interesting is that actually 40% of PanNET patients have mutation in genes which are regulating the chromatin structure, the epigenetic status, for which yet We don't know much, and there is no specific therapy or specific therapy targeting these mutations. These are MEN1, which it's known to be mutated in endocrine tumor for a very long time, and more recently in 2011, DAX8-TRX has been found mutated in often as in association with the MEN1 in a quite a big number of patients. So genomic tells us already, gives us additional information. We have a mutational status, and we can probably we can think about a certain therapy specifically target mutation. We can also look into prognostic marker. There are several. One of them is, for example, a DAX8-TRX. Because when it was described, the first described mutation in DAX8-TRX in PanNET in 2011, we started to look at the expression of DAX8-TRX in the tumor tissue. And what we did find is that it's true in 40% of the patient, DAX8-TRX expression is lost and is associated with the specific mechanism for telomerase maintenance, which is called ALT, which is also peculiar of these tumors. And this could also represent an interesting target because this is only active into the tumor cells, not in the normal cells, and specifically of this mutation. What we also found is that patients with patient with the DAX8-TRX loss would have a shorter disease-free survival. So this is an important prognostic marker that tells us that these patients might need a specific follow-up, or that needed a specific management because they have a high risk of relapse. And what we also notice is that DAX8-TRX loss occurs in the 95% of the case in tumor bigger than 2-3 centimeters, suggesting that this was something not occurring at the beginning. So it was not an initiation event, rather something occurring along the tumor progression, and then driving further the progression of the tumor and ultimately metastasis. And back in 2014, we didn't know exactly what was the mechanism by which DAX8-TRX loss would drive tumor progression. And now we start to have some ideas of how this could work, and I will talk about this later. So prognostic markers are extremely important, and they tell us a lot about tumor behavior. I'll just give you an example, but there are many other markers out there which can be extremely useful. So these three molecular characteristics that I just illustrate are kind of classical things that that in the history of pathology usually do accept the genomic for PanNET, but this is something that it's quite often done, is usually done routinely, and also DAX8-TRX expression is acquired more and more importance in the routine management of this patient. But there are other things, and today I would like to talk to you about Epi Genome, which is something which is, of course, a bit a new thing, so that we definitely don't look into the we're not looking into that in the clinic yet, but I think it definitely has a great potential, especially for pancreatic neuroendocrine tumors. When we talk about epigenome, we refer to so something that stays on top of the genomic. So if we imagine the DNA as a sequence, as a stripe, the modification are something that occur on top of it, and they influence the structure of the DNA. So how the DNA is organized, whether it's very condensed and close, we call heterochromatin, which means that the genes are not expressed, or the DNA can be more open and euchromatin, and the genes are expressed. And the two main epigenetic modifications are DNA methylation, which is something that occurs directly on the sequence of the DNA, so it's a methylation of a cytosine, and the modification of the histone, which instead occur at the histone, which are the proteins around which the DNA is wrapped. Epigenetic is extremely important because you have to think that we have one sequence of the same genome. All our cells in our body have the same genome. What makes the cells different among each other is the epigenetic status, and it's the epigenetic that drive the differentiation into the different tissue type that we have in the human body. So, which means that, so you can imagine if the epigenetic is so important for the differentiation, then it's probably equally important in driving the progression and the evolution of the tumors. And in fact, it was recently shown by Doug Hannan in the last chapter of the Hallmark of Cancer this year, that indeed epigenetic is one of the enabling characteristics which enable the cells to acquire all the hallmark of cancer, meaning all the characteristics that make a cancer cell a cancer cell. So it's extremely important. And why I think that is so important in PanNET, because I said at the beginning, 40% of PanNET have mutation in MEN1, DAX and A2X, and they are all involved in the epigenetic regulation. Specifically, MEN1 regulate the achromatin status, meaning the part of the genome which is highly transcribed, and A2X and DAX work as a complex and they're mainly involved in the regulation of the heterochromatin, which is extremely important for the maintenance of the genome stability, which is also extremely important for the cells. So, and if we look into the mutational burden of neuroendocrine tumor and pancreatic neuroendocrine tumor specifically, we see that they are extremely, they're much lower compared to other tumor entities, such as PDAC, for example, so pancreatic ductal adenocarcinoma or lung cancer. So we always thought that cancer is a disease of genes, but actually it's not only a disease of gene in this case, because in PanNET, in the progression doesn't look like it's being regulated by accumulation of genetic events, rather something else, and now we believe is in fact epigenetic. So when we went back to our model of regression, where we thought, okay, so now when we know that DAX was somehow, DAX and A2X loss was somehow driving the progression, now we hypothesize that actually what is driving the progression is are changes in the DNA methylation. So in the remodeling of the DNA methylation, so the epigenetic status, which then impact on the gene expression on one side, but also on the genomic stability. And this would then lead to classification of, so to different clinical outcome based on this epigenetic, different epigenetic profile, but also telling us something about the cell of origin of these tumors. And why it's important to know about the cell of origin? Well, again, it's another piece of the puzzle, right? So it's another information that we can add about these tumors, which right now probably we don't know. We don't know yet how to treat, but maybe in the future we might also have specific treatment for tumor coming from different cells. And it's important because the islet of Langerhans are formed by different type of cells, and specifically we have 5 types of cells: alpha cells producing glucagon, beta cells producing insulin, which are the majority of the cells, but also delta cells, epsilon cells, and PP cells. And all of these cells can originate a different type of tumors, and they can be very different among each other. So what we did is that, and this was the work done by a postdoc in my lab who now left, Annunziata Di Domenico. The first thing that we did, we compare DNA methylation profile of sorted normal endocrine cells, specifically beta and alpha cells. And when we found we use this difference between these 2 different types of cells to generate a phylogenetic tree, in which we align the DNA methylation profile of DNA isolated from pancreatic neuroendocrine tumor tissue. So these are all pancreatic neuroendocrine human samples. what we see is that actually these tumors cluster in 3 different groups. A small group at the edge of this site, very close to the beta cells, which are the beta-like tumor. Most likely these are insulinomas, actually not most likely, these are the insulinomas, so originated from beta cells producing insulin. On the other side, we have the alpha-like tumors, so tumors very similar to alpha cells, so most likely originated from alpha cells producing glucagon. And then we have a bigger intermediate tumors in the middle, which somehow lose progressively the differentiation from these 2 main cell types, actually mainly from the alpha cells, suggesting somehow a progression from alpha to this undifferentiated area. So we went further, so we wanted to confirm this data on immunohistochemistry. So we look for the expression of ARIA-X, which is the transcription factor of the alpha lineage, and PDX1, which is instead the transcription factor of the beta lineage. And we see indeed that we have tumors which express ARIA-X and glucagon, as we would expect. These are the alpha-like, the small group at the side. Tumors which are ARIA-X, positive for ARIA-X, but that lose the capacity of expressing the hormone. Tumor positive for both, suggesting again the differentiation from one or the other cell type. Tumors expressing none of these markers, and tumor expressing PDX1 and insulin, the insulinoma. So what we have is alpha-like tumor positive for ARIA-X, beta-like tumor positive for PDX1, alpha-like and beta-like, and then a larger group of tumor which are positive for ARIA-X, which means that they most likely come from the alpha-like, but that they lose some other feature of the alpha cells, such as, for example, the hormone expression. Where we check for the MEN1 and DAX and ATRX mutation, because we are specifically interested in this in the mutational status of these genes because of the epigenetic involvement. What we see is that beta-like tumors don't have mutation in MEN1 DAX. This was not surprising because we know insulinoma have a very clear and different genetic background. What we see is that alpha-like tumors are mainly mutated in MEN1, while the intermediate tumor have mutation in both MEN1 and DAX and ATRX. And I told you at the beginning, we always see DAX in the bigger tumor. So it looks like their small tumor have MEN1 mutation, and then they progress, acquiring DAX and ATRX mutation. This was confirmed by the clinical characteristic of this group of tumor. Beta-like and alpha-like tumor are small tumor, T1 and T2 tumors, while the intermediate tumor are a larger tumor, T3, T4, with a much higher increase of relapse. So these are the tumors that we have to look closer. And when we look at the disease-free survival, as a consequence, it's obvious to see that the beta-like and alpha-like tumor are quite indolent, while the intermediate tumor have definitely shorter disease-free survival. So Epi Genome, I hope I convinced you, it really tells a lot about pancreatic neuroendocrine tumors. It tells about the cell of origin. It can tells us about the epigenetic subgroup. And we really can stratify patients based on the molecular profile. One of the other things that we can look into is transcriptome. And again, in the work of Scarpa from 2017, but it's also true for the works by Anguraj, transcriptome clearly discriminate different group of PanNETs, and specifically one group of PanNET with a clear change in the metabolic, in the cell metabolism, and with the activation of hypoxia signaling, as well as the different immune landscape. When we went back, we also went back to our DNA methylation data, and we could see this group also using DNA methylation. So indeed we have which is this one. So indeed we have alpha-like tumor, quite indolent, intermediate tumor, and then the intermediate tumor with this hypoxia signaling and these metabolic changes, which are the ones that are aggressive and more invasive than other tumors, than the others. And when we look into the gene expression, we clearly see this hypoxia signaling activation, dedifferentiation, as well as changes in expression of gene-involving metabolism. So transcriptome is also extremely important and tell us again a lot about the tumor biology, can clearly distinguish PanNET with the different cell metabolism. Again, hypoxia, something that we could potentially target and think about a specific treatment for this subgroup of patients. So, good. Interesting. How we're going to test all these hypotheses. I mean, we're not going to run a trial for all of each of these characteristics. How we really going to see whether our hypothesis is true, whether we can really predict the response on cell therapy based on specific molecular background or specific marker expression. To do that, you need a solid and valuable in vitro model to perform an in vitro screening. And here is actually where PanNET stands really behind compared to many other tumor entities. And the problem is that we clearly we lack completely a meaningful preclinical model for these tumors, which is not, of course, the cell line nor animal model, which are not good to mimic pancreatic endocrine tumors. On top of it, primary pancreatic endocrine tumors do not grow in vitro. It's extremely difficult to maintain them in culture. There are alternative methods to try to overcome this problem. You can use precision cut slides. You can try to cultivate these cells for a short time in 2D, but the experiments are going to have will have a very short short-term experiment, and this, of course, is not be very meaningful for our purpose. PDX from PanNET also don't grow. This is also a major disadvantage. We have a very small success rate. Lately, there are quite a few groups starting to work on zebrafish, and this might be a promising model, and hopefully in the future we may hear more about that. And it could be that it could be a new model suite which we can exploit for such a purpose. So in my group, we tried to establish a 3D human primary PanNET culture to be exploited exactly for this purpose and with the aim of using for precision medicine. And the first thing that we had to do was to establish a very solid and robust international network, because you can imagine, I work in Switzerland, which is very small. Bern, my God, is the capital, but it's a very small city. We will never have the tumor volume to perform meaningful studies. So the first thing was really to contact different groups, and we have now a large collaboration, and we can gather samples to perform our studies. And what we wanted to do was to establish such a model, perform a drug screening, and then identify some molecular profile able to predict response in vitro of certain treatment. But most importantly, what we have to do is to correlate the response that we measure in vitro on the tumoroids on the patient, because we have to be sure that our model is meaningful and it's really reflecting the response of the patient. Otherwise, it's not very useful. So, and this is the work done by Simon April, a PhD student in my group. These are how the tumors looks like. They are very heterogeneous depending on the tumor, but in general, this is what we obtain from surgical specimen. And we have quite a good success rate. So we can get cells from almost 80% of samples, and we can do the experiment. We have enough cells to do the experiments in almost 60%. Although I have to admit, these are a bit older data, and now we got better, so we can. The success rate is definitely increased. And here is how the tumors look like. So this is the tumor tissue, and these are the tumoroids. You can appreciate that the tumoroids maintain the neuroendocrine characteristic, for example, synaptophysing. They have a certain level of proliferation comparable with the tumor of origin, and in case of functional tumor, as in this case, they still express the hormone. We measure the cell viability, which is in vitro, which is a surrogate to measure cell proliferation in a continuous way. This also allows us to do multiple screening, saving cells. And we found a very good correlation between the viability that we measure in vitro and the Ki-67 rate measure in the patient. What we also always do is to check for the tumor cell content before the treatment and at the end of the screening, because we want to be sure that we indeed treat tumors and not fibroblasts, for example. And this you have a case of the cells at the beginning of the treatment and at the end. And usually we have we still have a very high tumor cell content at the end of treatment. Here is just an example of what we do. So we treat all these samples isolated from surgical specimen with the 3 drugs which are currently used in the treatment of advanced pancreatic endocrine tumor: everolimus, sunitinib, and temozolomide. What we see here is that samples respond differently to specific treatment, and that the same samples respond differently to all these treatment, as it happens in the patient. So some patient will respond to everolimus, some other will not. And we see the same in vitro. What we don't know yet is that why some sample respond to everolimus or better to sunitinib than others. And this is what we are working on. So now we are performing molecular analysis of all these tumors, try to find some predictive or markers that can suggest that they could tell us which patient will respond better, which samples in vitro will respond better to specific treatment. And this is just a case-based study that we did in collaboration with Berlin, Charité Berlin, Bertram Wiedemann. We have very few samples. These are NET G3 NEC, so very aggressive tumors. And we treat them in vitro with cisplatin. And we see that there are some samples which have a low response to cisplatin and some other that have a higher response to cisplatin. And when we compare this with the response of the patient, we have a quite good correlation. These are very few samples, but still it's a promising result that suggests that our model could indeed be useful in therapy decision in such samples. So here is what we have so far and some ideas, and I would like just to think or just reason with you what would be the vision. How could we indeed implement precision medicine in PanNET, right? So I took the example of epigenetics because it's my favorite topic and because I really believe has a great potential in PanNET. But the first question is about when do we need to perform the molecular profile, right? So we're talking about surgery, for example, time of diagnosis surgery. We can make the epigenetic profile, which would tell us, yes, something about prognosis, because we know we can recognize very distinct PanNET subgroups. We know they have a different prognosis and clinical outcome. But if we want to use it for prediction, then we have to maybe do this tumor biopsies when the patient or metastasis tumor biopsies when the patient would relapse. And how about using a specific epigenetic treatment? This is just an hypothesis that we're exploring, because the beauty of epigenetic is that you can target it. It's reversible. While it's difficult to target mutation of genes, it's very easy to target epigenetics. So this is something we could, I envision is something it could really be feasible for such patient. And how about liquid biopsies? This is also something that is more and more used, and this is not invasive tool, which means that we could maybe even follow, if epigenetic changes it's a progression. So we know that epigenetic profile changes along progression. We could really maybe use it to follow the evolution of the disease and to intervene when we think is the right time. And how about the PanNET tumoroids? Should we do this for all the patients? Or maybe it would be just enough to identify specific predictive markers. And then once we have that, we would need to do this on the patients. You know, I don't have the answer for this. I'm not a clinician. I'm just a scientist. But I think we should really try to work together and try to move forward, because I think it's really promising in PanNET, and we're really standing quite behind if we're talking about precision medicine in these patients. So just to summarize what I just said, molecular profiling can tell us a lot about the tumor characteristic. We know about proliferation, tumors behavior, but also mutational pathways and specific pathways activation, but also prognostic markers are extremely important. And if you choose the right one, they can tell us, they could also be predictive for a specific response, a therapy response, or indication for a specific treatment. Epi Genome, I said, and I hope I convinced you, it's really the future, I think. Tells us about cell of origin, epigenetic subgroup, could be a possible way for treating patients. It could even use epigenetic drugs. Transcriptome, of course, is also extremely important. And we know that we use an RNA. We can really highlight a group of tumor with a specific change in cell metabolism, hypoxia signaling, which may need a specific treatment as well. And again, how to test all these hypotheses, we propose that our model, patient-derived tumoroids, is a powerful tool and a promising tool to test therapy response, and therefore to be implemented into precision medicine platform for such patients. With this, I'd like to thank you for your attention. I thank my group, of course, Terra, my supervisor, my boss, my mentor, everything, and the member of my group, Nunzia Di Domenico, and Simon, April, who did this job, but our collaborator in Milano, a group of Professor Falconi in Berlin, Bertrand Wiedemeyer, our surgeon in Bern, and the patient, of course, for giving allowing us to do the experiment using their material.
Great. Thanks, Ilaria. This is a fantastic talk, and giving an overview and covering the various aspects and showing from prognosis to the treatment prediction or new novel treatment that could come in. So I can already see questions coming in. I mean, Samira, you want to unmute yourself and ask?
I think it's just clap. I guess.
Oh, sorry. Yeah, I thought. Sorry. You have a question? I thought. Yeah. Okay.
I do have questions, but I don't want to necessarily go first. Congratulations.
Thank you.
Nice work. I can go first, but
yeah, please go ahead.
Yeah. Just to introduce myself, I'm an endocrine surgeon here at NCI and work very closely with Heidi, whom you know well, obviously on the surgical side, and have myself a lab where we work on similar things. And I know Aurel pretty well because I'm myself from Bern. So it's a funny circle. I trained in Geneva in terms of training, but so your work is impressive, evidently. Have you ever thought of doing single cell analyses?
Yes.
We are currently looking at, but
yes,
you're starting do. Or?
Yes, we have done it. These are all, I mean, unpublished, but really work in progress. So we still, we have few data that we are currently analyzing, and we have promising data. Yes. I mean, this is definitely, I wouldn't say this is something you can use for precision medicine. It's more something that tells a lot about the evolution and the heterogeneity of the tumor, which we see using,
Yeah, I think
yeah, we do that, but, you know,
key.
this very preliminary, so I don't want to say things because I'm not sure.
Yeah, I think it will be key, and I recommend that you guys do that since you have all these samples. I do think, because also, I guess I'm lucky I have someone here, Afsun Arda, who does single cell on the normal islets and has characterized the alpha beta cells. I guess it's publicly available, as you certainly know.
Yes,
but,
yes.
So I think that will be important. And so I wanted more specifically, and I think other listeners here are working also on SSTR2. Have you looked at SSTR2 specifically and how its loss fits into the tumor progression epigenetically?
Honestly, we haven't looked into that. I have to admit, we haven't looked into specific. No, we haven't looked into that specifically. I believe that progressively will be downregulated also by epigenetic, but we haven't looked into that specifically.
Okay, one last, and I let everybody else talk. Your generation of organoids, evidently we're trying that as well. With your new model, or the one you're doing the screenings on, how many generations are you managing, and when are you doing your experiments?
Okay, so I think this is a very important point. We are not talking about organoids. We are talking about tumoroids. I mean, here the field is very confusing, and
I agree.
So the names are just confusing. What we have, we don't propagate them. This is first generation, let's say. We have what we get from surgery. We put it in the plate. We treat, and that's it. We don't expand it. They don't grow. They will not grow. So we don't. That's the only
thing we've managed so far. Okay.
We don't even attempt to do that. It's actually even beyond our scope, because we wanted to have a right away screening, right? We don't want to wait 3 years, wait that maybe the cells change, or there is some genetic drift or whatever, and we don't even know what we have in culture. The challenge is to do this on the biopsies. This is the real challenge, and we start to work on that. And it's a challenge, but we will succeed for sure. But it's tricky. That's the problem. The material you start with is the one that you end with. That's it. They don't grow. I mean, neck, yes, but net, no.
So, and I thought Jadra would be the first one to raise the hand, but anyway, she's second still. So go ahead, Jadra.
Yeah. Well, thank you so much. First, Dr. Marinoni, was an excellent talk. It does take a village, right, in order to, improve the care in neuroendocrine tumors. And for me, I have to say that I applaud all the basic scientists, because usually patients are the ones who see our face, we treat the patients. But, I think it's important that they know what is the whole work behind that led us here. And I really applaud all the work that you're doing, and it is an amazing work. And let me tell you, I was inspired by all the work that you're doing. It's really amazing. And one of the questions I have is about, I was very intrigued, and maybe you mentioned about it, in terms of the neuroendocrine carcinomas. You have the one that were platinum sensitive, the one that responded to platinum versus the ones that did not. I was wondering if you can you explain to me, if in terms of, what you have seen, or maybe if you can explain to me what make them platinum sensitive versus not. I think that's important also from the clinical aspects as well, especially for high-grade neuroendocrine carcinomas. I think that's important to know. Yeah.
So here, the big limitation of this study is that it's a heterogeneous collective of samples, right? So we're talking about depth neck, so gastroenteropancreatitis. So we have a little bit of everything. We don't know yet what makes a tumor more sensitive than the others. We don't have this data. We look into, we sequence them afterwards, and we check whether we see differences in the responder and non-responder. There were no clear differences there. We're still working on that, but I'm not sure this is the right collective to draw any get any conclusion, because as I said, it's a very small one. It's almost a case-based collective. Statistical power is very limited, and so it's yeah, one should have a more homogeneous collective, more samples to be able to really get some conclusion here.
Right. And I mean, I'm happy to share that information with you, but, you know, here we have someone who is specialized on small cell lung cancer, and we usually kind of in terms of tumor biology, we have seen these high-grade neuroendocrine carcinomas, very similar to the small cell lung cancer, and also small cell lung cancer is considered a neuroendocrine tumor cancer as well. And there was a study that was done based on the neuroendocrine score, and I don't know if you're familiar with the neuroendocrine score. And basically what they saw is that if they have high neuroendocrine score, there may be responses to chemotherapy versus the one that have a lower neuroendocrine score that may be responsive more to other agents such as immunotherapy. So I don't know if you have looked into that, but I'm happy to share that information as well. So it's kind of like we have the replication stress scores, we have the neuroendocrine score. I don't know, it may be something that you may be interested in. I'm happy to share that information with you, because I think the fact that you were able to identify the platinum sensitive versus or responses versus not, I think that's very interesting, at least from the clinical perspective. Yeah.
Yes. I mean, I know. Thank you very much. This is a precious information. I will look into that. We will look into that for sure. It's just that, yeah, I mean, in vitro, we see difference. Let's say we see differences. One is more responder and the other is not. Then we don't know which is the, you know, how much is responder is responder and how much not responder. So it's difficult to you know, to have a clear cut between respondent and responder. And as I said, this was a very small collective. Maybe it's not the best one for performing such a study. But yes, thank you very much. And it's something we'd definitely look into.
Great job. I was really inspired by you today. Thank you.
Thank you.
Any other questions from others?
I had a quick question. So that was a wonderful presentation. Thank you. And you had mentioned, you know, targeting the Epi Genome. Can you talk a little bit about what you had in mind in terms of how you would target the Epi Genome? Are you thinking like HDAC inhibitors? You know, those aren't as super specific, but yeah, what did you have in mind when you were saying targeting the Epi Genome?
Yeah, that's a good question. So there are several options there, right? The problem is that the data we have so far about epigenetic profile of tumors, pancreatic endocrine tumors from the patient comes mainly from DNA methylation, actually only DNA methylation, which is one part of the whole picture, right? And the problem is that it's difficult to get other type of information from, for example, ATASEC or ChIP-seq, because we are talking about most of the case paraffin samples, or impossible to perform ATASEC. Actually, we tried on frozen samples, but we did not succeed. So in the future, we might be able, but for the moment, we don't have such information. But I think there is definitely the the histone modification, which is something we could definitely start to look into. The problem is that we should know exactly which one for which tumor, right? That will be the future for sure. DAX and ATRX, we know they participate in the 3 methylation of the lysin 27 of the histone 3. So this is something. Lysin 9, sorry, of histone 3. So this is something definitely one could explore. There are other inhibitors like KDM5, for example. This has been found, KDM5, which is histone demethylase, which has been found amplified in a subgroup of PanNET as well. So there are different options there. There are also a paper on HDAC inhibitor on PanNET cell line. I think there are different options. I would go more in the direction of the histone modification, but we should have data on the chromatin structure of the tumors and not just on the DNA methylation, which is good for certain things because it's really easy to measure on clinical specimens. So that's why I think it's really promising in clinical application, because we can measure from paraffin samples. We can, you know, also for brain tumors, this is used for classify different tumors. So it's really powerful. For treatment, I think we should go rather on histone. And I don't think you just need epigenetic treatment to cure cancer. It probably is something you have to use in combination with with chemotherapy, for example, or other type of treatment. This could be something that sensitizes the cells, for example, to specific treatment. There is some work in other cancer type, for example, that this is the case. Which one exactly for PanNET, I don't know yet, but something I'm working on. Yes. I don't know if I answered your question. Sorry.
Yes. Thank you.
So our data is encouraging on cryopreserved samples for single cell APAC.
Your data. You have data.
Yeah, single cell from cryopreserved. We
from
cryopreserved to the fresh, which we were able to get, and it looks fairly, you know, comparable.
Good. We try on cryopreserved, but not so successful.
Okay.
But I
guess we can share one day that.
Absolutely, we can. Yeah.
If you have the best, but
yes,
can't, it's just not possible. At least our samples come out usually late in the day. And then to do the whole processing, it's just impossible. Yeah.
Cryopreserved.
I might jump in as well because we're doing the ATAC-seq as well, and we've had some success. So maybe we should all get together and discuss at some point.
We're also working on that at UAB. We're doing RRBS on paraffin-embedded samples.
Okay, good.
Good. So we'll have a lot of data soon about that. So
great. I think I have a few questions with probably offline we can connect. Already I can see that quite a lot of interest and collaborations, potential collaborations that it looks like going to happen. And I'm glad, and I'm sure Selena would be glad that through this forum, this could be facilitated. May I just leave it to Selena then? Yeah. Thanks, Ilaria, for this fantastic.
Thank you for the invitation.
Oh, thank you so much. That was amazing talk, really, really interesting. And yes, please do all collaborate with each other. That is the whole point why Simon set this up, to encourage collaboration and to ultimately to find a cure. So thank you so much for coming. Again, I would just say for those that weren't here at the beginning, it is our virtual conference on Friday the 20th of May, starting at 5 p.m. UK time, which is 9 a.m. Pacific time and 12 p.m. Eastern time. It's about 3 hours long. We've got 5 speakers, and just keep an eye on social media, and the details will be up very soon. And thank you again. Thank you so much for coming, and no Netchatter in May because of the conference. So hopefully we'll see you there, and then next Netchatter the last Thursday in June. So thank you very much again, and I'll see you all soon. Thank you. Thanks. Bye-bye.
Bye. Bye-bye.
Bye. See ya.